So Robin is a physiotherapist with the heart and lung transplant programs within SickKids Transplant and Regenerative Medicine Center and the Labatt Family Heart Center. She's actively involved in professional transplant associations and interest groups, and including the Canadian Society for Transplantation. She's a Can Restore Steering Committee member and in the International Pediatric Transplant Association. Her clinical and research interests include neurodevelopmental outcomes and long-term health and fitness in pediatric transplant recipients. So Robin today will be presenting a clinical case, use of virtual rehabilitation through heart transplant journey, the case study of a pediatric patient with a ventricular assist device. Thanks, Robin.
Thank you. Can you hear me?
Yeah.
Thank you very much for the opportunity to share my case today. I have nothing to disclose. So as a bit of background, ventricular assist devices, and I'm going to call them VADs for the remainder of the presentation, are increasingly being used to support end-stage heart failure, and they're often used as a bridge to transplantation. There's well-documented exercise limitations in end-stage heart failure with or without VAD devices, but there's limited evidence looking at exercise conditioning in children with these devices, and none of the work has been with virtual care. Exercise rehabilitation post-VAD insertion typically happens at SickKids due to a lack of appropriate resources for them in the community, and often these children stay close to the hospital. But the current pandemic necessitated a change in delivery of our usual program. So my purpose today is to just describe the transition to virtual rehab of a pediatric patient requiring VAD support to transplant during the current pandemic period. So I'll introduce you to our case, who is a previously healthy 16-year-old boy with complex congenital heart defect. He presented in January of 2020 with signs of heart failure, and his activity was quite limited with a 6-minute walk distance of only 366 meters. He underwent VAD insertion as he continued to deteriorate on February 17th, and that surgery was quite complicated, necessitating the need for a second sternotomy or a second surgery a few days after the first, which resulted in a very long intensive care stay. And as a result, when we assessed him, he had, after that ICU stay, he had significant pain and many musculoskeletal issues. He was generally deconditioned, and he had really lost a lot of functional skills and independence, requiring assistance even for basic ADLs and walking with a walker. So his needs at that time were for physical rehabilitation, but also the family needed to learn a lot about living with a VAD, managing the VAD, and this was all in planning for a discharge home to wait for transplantation. So the team worked with him for a few weeks and eventually got him to readiness for discharge. However, the timing wasn't the best. The pandemic was declared on March 11th, and he was scheduled to be discharged from hospital on March 12th. And at that time, everything shut down, and local discharge to what we would use was Ronald McDonald House, where he would have easy access to rehab with me, was no longer possible. Instead, we were discharging him home, which was 2 hours away from the hospital. However, the family was open to trying virtual rehabilitation. So I had zero rehabilitation virtually, any experience with that at all, and had to think of quite a few things in terms of maintaining the safety if we were going to be doing this. On the left, you see the modified Borg rating of perceived exertion. This is one of the tools we use to monitor his exercise intensity and his tolerance. It's self-reported, and whenever we would start something, we would start on a low intensity and gradually increase it, monitoring symptoms closely. His mom, who was his primary caregiver, was present during every session to ensure that we had a good eye on the situation, because sometimes the visual quality or video quality was not optimal. We had a safety plan in place about when to stop the session, who we would need to call if something were to happen. And we also have an emergency plan, but some of that work was already done just because he had a VAD in place. But we discussed it in the context of our virtual exercise sessions. We needed to have a good plan. We needed to set up space, and this is my space and his space. So you can see the limited equipment we had, but we needed space to demonstrate and to perform the exercises, access to a phone so that I could call should something be, urgently needed to be addressed, whether it's calling the family or calling the team about something. There were lots of learnings as we went through this over the past few months. Some were, I think, anticipated and some not so anticipated. I knew that I would have a big learning curve with respect to the technology, having never done virtual rehab in the past. The teenager himself was quite good at the technology, but figuring out where to put the camera so that I could see things like knee angles or position of his body was a sort of ongoing challenge. Not having a full gym at my disposal was also a challenge. So when he had limited equipment, I think, which Lisa's already kind of alluded to, how that can be a challenge. And also having to explain things virtually or verbally, instead of being able to put my hand on and saying, no, your arm should be, or your leg should be in this position, was also one of those challenges. And we knew going in that any new issues that might crop up would require virtual assessment, and needed to think about how we would manage that. Some of the unanticipated challenges, I would call them, I think that caught me by surprise, were around fatigue. It was very surprising to me how tired he was and how tired I was at the end of the sessions. It not necessarily a physical fatigue, but the one-on-one sessions could be, the flow was very different. It could be quite intense. We needed to learn a different communication strategy just by the virtual nature. Often the technology was delayed. Learning to live with gaps in the conversation, learning to modulate the speed and volume of the voice, which is kind of just the practical aspects of working virtually. And a long, 45 to 60-minute session of face-to-face can be quite tiring and quite difficult. So giving him breaks when he needed to sort of disengage from the session and chat with his mom for a bit. I asked the family for feedback, and they had a lot of positive things to say. I had a session with them earlier today, and they echoed some of these things. One of the biggest things for them was decreasing the visits to the hospital, which at this time of social distancing was felt to be worth any effort possible. They also thought by learning the exercises that I was doing with them at home and the progressions at home, that the carryover was better, because they weren't so intimidated to try these things at home when they'd already had. They had significant, they live in a more rural area, and they had significant issues with technology in terms of the Wi-Fi access. They actually changed carriers halfway through this journey. They had preferences as to which online platform we used. And our second or third session, we introduced music, and that was felt, he just thought that was the best thing to actually make the sessions more bearable, add to the enjoyment, keeping him motivated. So we always had music running, and choosing that music to actually match the intensity of the workout became a bit of an ongoing fun activity for us during the session. So we continued to work together, and I was even able to introduce a physiotherapy assistant who was able to run sessions on her own on May 7th, and he underwent successful heart transplant on May 16th, shortly thereafter, was discharged from hospital post-op day 6 on his feet, walking without a walker. His 6-minute walk distance we recently were able to measure was about 360 meters, which means we've gotten him back to where he was prior to 3 open heart surgeries in less than 4 months. And we continue with his rehab with a combination of on-site and virtual visits, because his medical follow-up is a little bit more intense right now, being that he's so close from transplant. So in conclusion, this was my first experience with virtual rehabilitation, and certainly the first that I've seen with pediatric patients with VADS. It is certainly feasible and has the potential to improve the family experience, I think, by limiting the need for them to travel to the center. But I would have to say that family buy-in is essential from a safety perspective and from an engagement perspective. And I think we need to have further experience to really evaluate it fully. But speaking personally, I have expanded this. I'm using it with children who are pre and post lung and heart transplant. And I'm going to start following a baby virtually who's listed for a heart. So I think that we'll eventually get that experience. Thank you. I'm open to any questions.
Thank you so much, Robin, for sharing your experience and your challenges, and just being honest about how new this was for you and how you were able to manage it. We don't have too much time for questions, but there's one that's come up a couple of times, which was, what was the platform that you used and what did the family prefer?
So at SickKids, we initially started, we had access to OTN, the Ontario Telehealth Network platform, through DeskLink, and that worked really well for me because it integrated with our healthcare documentation system. Shortly after that, about a month after sort of the pandemic hit, we were able to use the Zoom platform, and the family much preferred Zoom. He was so much better at it than I was. I mean, he taught me a lot about actually using it, and they just preferred it for ease, just being able to click on it and not having to really worry too much. It just seemed much more user friendly for them.